Good morning, everybody. Welcome to our sixth webinar of 2021. I am Lydia Miselides, the Executive Director of the Alliance for Leadership in Education and your host for these webinars. We have just surpassed 314 people joining us today. Welcome to all of you, providers, managed care partners, state colleagues, and others. Thank you for joining us today. The webinar is being recorded and can be accessed from the CADS website for later viewing or listening, probably later today or first thing tomorrow morning at the latest. And as always, thank you to the CADS team for your continued behind the scenes support. Pam sent out an email this morning. Normally it has our handout attached to it, but that handout will be available either during the webinar or later after the webinar today. So either way, you'll be able to access it if you look at the handout screen to the control panel at around 11 or so, or we will be sending it out to everybody. And this is always a listen-only format, but we do encourage you to submit your questions and comments through the question box, again, to the right of your screen in the control panel. And we do hope to be able to get to some of your questions today. We are also grateful to the Archstone Foundation for a second round of funding to continue to make these web talks possible for you through October. And we hope that those of you who are joining us today who are not CADS members, you will consider membership as this new year begins so that we can welcome you as part of this virtual community, and that you can lend your support to all of the fantastic efforts that CADS is making to advance our field and create a stronger future for all of us as we begin to emerge from this pandemic. So I wanted to also let you know that if you do join CADS, you become a member of the Alliance for Leadership and Education. So that's a little bonus for you to incentivize you to join. The month of March brings us to our almost 1-year anniversary of the pandemic. It's unbelievable. It's also a month to celebrate women's history and our fabulous social workers. It is Social Work Appreciation Month. So round of applause for all of you out there who are listening, who are social workers. We appreciate you all. It is also Disability Awareness Month, making March a really great month to celebrate many of the people we serve and the policies that make our centers click. Our previous web talk featured presentations from the State Department of Social Services COVID team, and they talked about vaccines, access to vaccinations, and they were joined by 2 CADS providers who talked about how they partnered with local pharmacies to set up an on-site vaccination clinic at their centers. So you can see here, this was scored a 4.7 out of 5. High score. One person said these webinars put me and my staff into proactive and action mode. Another person said every webinar is valuable, really appreciate the subject matter experts and sharing. So thank you everyone for your comments and for completing the survey. We read every single comment that comes in from you. And we can also see from the evaluations that more of you are asking for training on how to prepare for recongregating back at your centers. And we will be turning our attention to that. You'll hear a little bit from Jill Sparrow in a moment to understand how we're preparing for instructions that will be coming out to you. And we'll continue to work on that over the next couple of months, but training will be forthcoming. So our agenda today is really jam-packed. We're going to hear from Jill, as I mentioned, from the California Department of Aging, Chief of the Community-Based Adult Services branch. And then I'll bring your attention to a new Department of Social Services provider information pin. We'll hear from Richard Lee, one of our vision team members and an LA County provider, and he'll give us a little overview of what he has learned about vaccination resources in the county and also statewide. I'll talk a little bit about the new prioritization and tiers. and then we'll be welcoming Dr. Monica Gandhi at about 11 o'clock. So I'm going to introduce Dr. Gandhi here before she arrives, so you will know who she is before she joins us, because we want to jump right into her talk. She is the Professor of Medicine and Associate Chief Division of HIV, Infectious Diseases, and Global Medicine at UCSF. And she has done her residency training there and then remained to achieve these positions. She's also the director of the UCSF's Gladstone Center for AIDS Research and the medical director of Ward 86, which is the HIV clinic at San Francisco General Hospital. So after her residency at UCSF, she also obtained a master's degree from public health in Berkeley and focused on epidemiology and biostatistics. So you can see why she's such a fantastic person to have join us today to talk about the pandemic. Her research interest is identifying low-cost solutions to measuring antiretroviral levels in resource-poor settings. So she has been out in the community measuring the incidence of COVID-19 in underserved areas in San Francisco. She is going to talk today about the factors that we all need to attend to in order to enjoy a safe re-entry back to our centers, and what kind of remediation factors we need to be attentive to, like masking, distancing, ventilation, vaccination levels, and transportation. And she's also going to talk to us about the variants that are circulating, and they've been on the news quite a bit lately, and what studies are showing about transmissibility after vaccination, and why the just approved Janssen vaccine offers good protection. So she'll help us think through these things today and share what she sees as your role in reducing harm for your vulnerable populations. And when I spoke with her Friday, I learned that she not only teaches and does this research, but she's also seeing patients at clinics. So she definitely has a hands-on, on-the-ground experience and has actually referred and worked with patients who have attended Stepping Stone in San Francisco. So we're really fortunate to have her today. As I said, she'll be joining us at about 11 o'clock. So with that, I would now like to introduce Jill. I think Jill needs no further introduction. She is the chief of the CBAS branch at the Department of Aging and joins us for these web talks frequently. And today she's going to offer some updates and some newsworthy items to share with all of you. So Jill, welcome aboard.
Thanks, Lydia. Hi, everyone. It's nice to be here and join you today. I'm happy to just provide a few updates on what's been happening and answer a couple questions if we have some time. So, like I said, just a few updates. And the first update has to do with personal protective equipment. All program directors, administrators should know. We sent out an email last week informing everybody that personal protective equipment is available again through the California Office of Emergency Services. And in that email that came through also had an order form attached to it that was modified specifically for CBAS providers. So that personal protective equipment again is available for order by providers. Since we sent that out, we've made just a couple of minor changes to the process, and we will be sending out another email, another communication to all administrators and program directors in the very near future about those changes. So please keep an eye out for that. One of the changes that we did make actually has to do with the email address where you will be sending those PPE orders to. So you'll still be sending them to the Department of Aging, but the email address will be ppe@aging.ca.gov. So don't worry about getting that down or writing that down today, because the email that you all get will come from that email address. So you will have it, and we'll make sure of that. Also, there's one change to the instructions that the previous instructions stated that providers could order up to a 2-week supply of PPE. That is changed to will now be able to order up to a 1-month supply of PPE. And also the timing of orders will change a little bit. Instead of the 10th of the month, it will be during the 3rd week. Those details, we'll communicate those in an email again that will be sent out in the near future. So if you didn't catch that today, again, be assured we'll be sending that out in writing. So keep an eye out for that. And once again, we just thank you for kind of your attention to getting those orders in as needed, and Becky Hinkson, who has been assisting us with those at the office, has been doing a great job and working hard to get those all processed as quickly as possible for everybody. Okay. The next update just wanted to provide was we've been getting a few questions from providers and others regarding the task flexibilities and the expiration of those. CMS, as all of you know, had provided federal approval for these program flexibilities during the public health emergency, and they were officially approved back in October, and they are set to expire this month on March 12th. However, I just want to rest assured our partners at Department of Healthcare Services are working currently with CMS on extending those flexibilities, and we anticipate that they will be extended moving forward for a duration of time. I don't have any dates to share with you today, but I just wanted to let you know that we anticipate that those flexibilities will be extended, and will continue to operate under task for a little bit of time to come. Just the third update and final update just wanted to provide today. Lydia alluded to it when we began the webinar, is that we know, and we've just as a follow-up to our webinar that we hosted back on the 18th of February, I guess it's just really a couple weeks ago. We are working on guidance for providers as we look towards the transition back to center-based services. We know we will be transitioning back to center-based services this year, and we know you all are eager for some more guidance information on what that's going to look like, what that process will be, and what the expectations will be. So CDA, we anticipate releasing some guidance around that, probably likely in April sometime, and that guidance will speak to that transition period, and will clearly outline expectations and requirements for service delivery, for staffing, for documentation, facility readiness, et cetera, all of that moving forward. So again, we know everyone is eager for some more clarity and kind of and what's really going to be happening for that transition. I also want to say too, probably expect too that we will have clearly kind of outline some dates for everybody, where we'll have a launch date, and then we'll have an end date, where an end date meaning where we expect providers will be fully back into the in-center provision of in-center services. So hoping to provide some more a framework for that for all of you, and some more clarity as we move forward. So please expect something. We anticipate, like I said, in April to get that out, and we'll also be providing some training around that guidance when it's released. So more to come on that. And as always, we know our partners at ALE and CAS will be instrumental in providing training and education on best practices related to that guidance. So it will be, once again, kind of partnering to provide you with as much information and training and as we can. I think, Lydia, I think those are my updates for today.
Those are fantastic. I have a couple quick questions for you, Jill, that have come in. So the first one is from Ed. He says, I've requested PPE using the form provided previously. Do I need to resubmit a new form?
When you say you used the form provided previously, if you mean the form that was sent out last week, no, you would still use that form. I know a while ago last year, I think we had some forms. There have been some different variations on those forms circulating. That's why I'm not quite sure what he's referencing. But if you're using the form that was sent out last week with the email to providers, then you should be fine.
Okay. So use last week's form. If it was from a year ago or less than a year ago, that is not going to be
Correct.
active. Okay, perfect. Thank you for that question, Ed. And then Lucine is asking, is the PPE only for centers who are providing any level of in-center services, or is it available now for staff and for participants who might need, say, cloth masks at home?
It's for any providers who are in need of PPE right now for any type of services that you're providing, whether it's in center or for staff, or that's fine. And we expect providers to order it as needed.
Okay, terrific. So content, I mean, put in your orders and your requests. What you get may not be exactly what you order is our experience, but at least get those requests in, and I'm sure it has to do with supply that the state has. So thank you, Jill. I appreciate that very much. I now want to just briefly go over a new Department of Social Services provider information bulletin. So for those of you who are licensed under Department of Social Services, you may want to take a look at this. And I cannot tell you if this applies to licensees through the Department of Public Health. I didn't have a moment to search that out, but this seems like good general advice. So the CDC has given some guidance about TB testing and the timing of that, along with COVID vaccine. And obviously COVID vaccine is a very high priority. So this pin is basically saying that they, at the Department of Social Services, for new employees, they are temporarily waiving the TB testing requirement if it coincides with a person receiving a COVID-19 vaccination. So they want people to wait 5 weeks after their final dose of COVID vaccination before they get a TB test. In the meantime, there's a questionnaire that new employees would fill out. It sounded like it was kind of an attestation, if you will. So again, those of you who are licensed and you are looking at hiring new employees, please do take a look at this pin. It's numbered 21-03-CCLD, and the date on it is February 26. So you can look that up easily online. So next, I would like to welcome Richard Lee, who I mentioned earlier has been a member of our crisis team, now renamed the Vision team, since last March. And he has been our go-to person for keeping track of what's happening in LA County with vaccines and vaccinations. So he's going to share with us his on-the-ground experience and some information that also applies to all of us across the state. So welcome, Richard. Thank you for joining us today. Always appreciate it.
Thanks, Lydia. Thank you for having me again. As Lydia said, I've been kind of keeping up to date with everything vaccination related, especially because of our center, which is in Los Angeles, but also just because of everything going on. And I don't have specific clinical expertise, so I think all those questions should go definitely to the doctors. But I myself have been the one that's looking for everybody within our facility with staff and also participants. And I also work with language support at a vaccination clinic in Los Angeles. So I have kind of firsthand kind of struggles and experiences as well. And so I wanted to provide a little bit more of a LA County perspective as well as a statewide perspective, because I know all the providers and everybody is in kind of different stages of vaccination, even within this time. And although we have been open with staff and participants to be vaccinated for a while, I know everybody's had a little bit of a struggle to get vaccination appointments at different locations. And so I'd like to provide a few resources. The specific one to LA County one, which is the easiest to tell participants and other people, is www.vaccinatelacounty.com. And it should take you to a site that is easily navigatable. It has links to book an appointment. And then it has, I guess, different securing second dose appointments, information about second appointments, who they're vaccinating, and kind of general information as well. I think even if you don't reside within LA County, it might be good to kind of take a look at as well. If you're behind and you're still in a 1A kind of area, then I think LA County might be an area that would shed a little bit more light on what potentially the next steps could look like as well. I think statewide, I think everybody in California is using specifically the myturn.ca.gov website now, which the state is heavily investing in and kind of directing people toward. The local sites operated by FEMA, the Cal OES, CalStat LA sites, as well as the one in Oakland, use the myturn.ca.gov, as well as the counties and also community partners. And so I think even if you're not in Los Angeles County, you're probably going to be using and probably sharing the links for myturn.ca.gov to specifically book appointments for participants as well as staff. And this is for all applicable phases as well. And so it's not just going to be for ADHCs, but for the newly eligible food workers, educators, as well as emergency personnel. Everybody's booking through MyTurn, which also adds kind of complications and challenges because now we're, all fighting for appointments as well. The second one below is Carbon Health, and this is, I believe, LA County specific. I know Orange County uses Athena, and other counties use different other sites for scheduling appointments, but the Carbon Health ones are the ones that are used by the LA County Fire Department, or the LA City Fire Department pods, such as Dodger Stadium, Hanson Dam. And so I think this also illustrates that there are multiple avenues for booking appointments, which also kind of adds another complication because it's not just one area that we have to keep monitoring for appointments. And the third one I'd like to mention is the PrepMod, and also it's known as CalVax, the website, www.calvax.org. And I think it's the one most used by individual clinics and pharmacies that might not be associated directly with the county. And so the ones that go through CalVax and PrepMod usually have their own individual links. And those are also found if you go to the Vaccinate LA County website and click book your appointments, you can scroll down and see the different ones. And this is used statewide as well as nationwide as well. I've seen other states using the PrepMod CalVax navigations, and they usually show up with individual slots. Next slide, please. And so I wanted to kind of provide also the differences between the MyTurn, Carbon Health, PrepMod, and kind of the high-level overview of the county, because I believe this is parallel to other counties as well. We have things working through specifically the LA County, the city, and then individual pharmacies and clinics as well. And so the vaccination sites in LA County, which is operated by the Department of Public Health, are actually right now only offering Pfizer. And this is really important to note because I know as we follow up with our second appointments, it's crucial to have the second dose be the same manufactured drug as the first dose. And so a lot of sites are scheduling the first and second dose together, but in the case that you are scheduling appointments at sites that don't offer automatic second appointments, then we need to make sure that we're scheduling and kind of attending sites that have the same drugs. And so the megapods, the FEMA sites, Cal OES are all using Pfizer right now in LA County. And these are the megapods directly operated by the county public health department. And these are the ones that are going through MyTurn, as you can see. Below the LA City ones are all Dodger Stadium, Hanson Dam. The ones operating Carbon Health are all using Moderna. And so that's kind of specific to that area and the LA City Fire Department. And so both MyTurn and Carbon Health automatically schedule second appointments when you book your first one. And so that's kind of a convenient thing to have. And then below we have individual pharmacies and clinics. And by pharmacies, I'm talking about neighborhood pharmacies as well as Ralph's, Albertsons, Save-Ons, Rite Aid, Costco. All of these individual providers have their own sites. And even within that, some stores locally have their own sites within that as well. And so it's very complicated and cumbersome to kind of comb through. But at the same time, if you don't find your appointments available on MyTurn or Carbon Health, it might be very useful to go through the individual links via CalVax and the individual pharmacy sites to be able to find local spots that might have appointments. And then I'd also like to mention, it might be also a good idea to talk to different providers and also call different community clinics to see if they're even offering maybe walk-in appointments. The site that I am volunteering at, they actually have walk-in appointments for seniors and people with disabilities over the age of 65. And so for the people that can't schedule appointments or can't do that, I think that might be an option to think of as well. And so that varies by community clinic. MyTurn and Carbon Health, all the LA County and city sites do not offer walk-ins. And so that's kind of something to think about. And then lastly, with this section, the sites can be either drive-through or walk-up. I know this is a very important point as well. And so I think we need to keep track when we're sending people to make sure that sites are walk-up if we are indeed taking people by public transportation. And then if sites are drive-through only, then we need to make sure that our participants or staff members have those resources as well. I'd like to mention the fact that beginning this month on the 1st of March for LA County, we added the eligibility for food and agriculture, emergency services, and education and childcare. And so whoever's working in those sectors are now booking appointments as well, which kind of doubles up and increases the pool in LA County by about 1.2 million people. And so I think a lot more people are receiving or trying to get appointments as well, which might lead to a lot more challenges with the different sites that are creating appointments. And lastly, can we go to the last slide, please? Next slide, if possible. Thank you. And so the site that we're using statewide, I'd like to take a little bit of time to kind of go through the navigation. I think this is important because I myself am using this site a lot, but at the same time, I'm sending this link, myturn.ca.gov, to different people that need to book by themselves. And so having a little bit of a mental picture of how it looks really helps into kind of explaining how the process is. And so if you go to this website, it's actually now available in 8 different languages. And so people without the English capabilities are still able to use it as well. And so you can choose your language and then go to the next page. And you basically choose which healthcare or which eligibility criteria that you're using, as well as your age. It has the different check disclaimer boxes that you have to check off mandatorily. And then it will let you know if you're eligible or not. So right now, if you go to LA County, if you choose LA County, choose your age, and then if you say you're a food care worker or a healthcare worker or whatever eligible you are, it'll give you congratulations, you're eligible, and then it'll tell you to put in your zip code or address. I actually find it very helpful just to put the city that you're living in. So for us, we would just put Los Angeles instead of putting our individual zip code, because it kind of broadens the resources that MyTurn returns to you in terms of a radius of available sites. And so if you're in San Francisco, I would just put San Francisco instead of the individual zip code. If you're in San Diego, same as well. And so after that, it should give you the availability and kind of different sites that are offering the different vaccinations. And through this MyTurn website, you will be able to, at the same time, book your first and second appointment. The MyTurn right now, most of them are offering Pfizer, so it'll book your first appointment, and then your second appointment will be 3 weeks later on the date as well. And so this is probably the site that we're going to be visiting the most and using the most. And so I wanted to kind of illustrate a little bit step by step about how to book appointments through that. I think appointments, they generally are released later in the evening and early in the morning as well. So it kind of helps to keep checking and kind of keep going through it as well. And so I hope that helped. And if anybody has any questions, I would be happy to answer. And with that, I'll turn it back to Lydia.
Thank you. Thank you so much, Richard. Great overview. We've got a couple of comments in the question box if folks want to take a look at that about some possible sites that are open in Los Angeles. So thank you, Vic, for those comments coming in. And Diane shares that that's really valuable information, Richard. Thank you. And be sure that new sectors of workers take pay stubs with them when they go for the vaccination. So now we're going to take a look, following up on that and sort of setting the stage for Dr. Gandhi's talk. We're going to take a look at some additional prioritization groups that are coming online March 15th. So Richard talked about the March 1st groups, and remember, every county can determine the next tier of people that they want to open vaccinations to. So this does vary county to county, which is why we've advised you previously to really pay close attention to your county websites. So March 15th, really good news. The state has opened up vaccination as supply allows to people with existing chronic conditions. And you can see the list here. I'll just highlight a couple that I think relate to many of the people you serve: chronic kidney disease, chronic pulmonary disease, Down syndrome, heart conditions, excludes hypertension, severe obesity, diabetes, type 2 diabetes. So that's going to be a familiar list to many of you in terms of conditions that your participants have. The other group is those who, as a result of a developmental or other severe high-risk disability, one or more of the following applies. And you can see the list here, but I will read it out loud for those who might be listening later. An individual is likely to develop severe life-threatening illness or death from COVID-19 infection. Acquiring COVID-19 will limit the individual's ability to receive ongoing care or services vital to their well-being and survival. The third is providing adequate and timely COVID care will be particularly challenging due to the individual's disability. So that list, as you can see, is much broader and likely encompasses many of the people who you serve who are under the age of 65 and otherwise may not be eligible. So we're very excited and happy that the state included this list of new people who are eligible for vaccination beginning March 15th. I do not know, a question has come in and I do not know the answer as to whether or not people can begin making appointments now for March 15th. So if anyone has the answer to that question, please put it in the question box and I can share that with everybody. Okay, that's a great question. So the good news is that vaccines are beginning to make their way into the counties at a little bit more regular pace than previously. We know that the Arctic storm delayed deliveries a week and a half ago, but those are now getting caught up. And those of you who had cancellations of your vaccination appointment probably got rescheduled relatively quickly. And we do expect now that the J&J Janssen vaccine has been approved under emergency authorization that we'll see even better supply coming to California and to the counties. And then many of you heard probably on the news yesterday that President Biden said he believes that by the end of May, there will be enough vaccine available for every adult in the United States who chooses to get vaccinated. The issue may still be supplies and personnel to administer those vaccinations, but I think that's another really positive piece of news that we can hang on to. So the other hopeful news that I'm sure many of you have already seen, but I wanted to point out to you again, setting the stage for Dr. Gandhi's talk, is the third wave has peaked and we are on the decline relative to daily cases and death rates. And as we know from these webinars, the death rate, deaths always are a lagging indicator relative to positive cases. So you can see the graphs here show us that we are definitely on the good side of that third wave. And this is also a piece of good news. As you recall, there was an intense focus as soon as the vaccinations came out on getting them into the arms of people who reside in nursing facilities and in assisted living facilities. After a bit of a bumpy start at the 1st of January, we are now seeing the result of those vaccination efforts. And again, you can see this graph showing outbreaks have significantly dropped. This is as of January 31st, so this is a month of data lag. The incidence rate, mortality, and overall mortality, which is interesting because it sort of tracks the COVID mortality in its decline as well. And another piece of data that basically supports what we've just looked at, and that is the R effective value. So the R effective value in epidemiology, and I had to look this one up because I've heard of the R productive rate, but not the effective rate. So the effective reproduction number is the number of people in a population who can be infected by one individual at any point in time. And this number, the effective reproduction rate, changes with the rate of immunity in the population that's being looked at. So this is at 0.79 right now, which is less than 1, which is fantastic because that means every infected person is capable of infecting 0.79 of another person. So you can see these are different estimates here. And the dark blue line is the aggregate of all of these estimates. So you can see it started breaking the number 1 at about January 3rd and has been on the decline. I don't know what this little uptick here means. We'd have to ask an epidemiologist about that one. Okay. And then the other good news is that those of you who are in the counties that were recognized with yesterday's announcement that are moving from the purple to the red are going to be able to experience some new openings. So most of the state, as you all know, has been in the widespread purple zone, and that has been pretty restrictive. These counties that are listed below here, Del Norte, El Dorado, Humboldt, Lassen, Marin, Mariposa, Modoc, Napa, Plumas, San Francisco, San Luis Obispo, San Mateo, Santa Clara, Shasta, Trinity, and Yolo are now in the red tier. Everyone else is still in purple, except for Alpine and Sierra. They're in orange. As you know, in Northern California, those are low density population counties. So being in the red tier now, that means that gyms can reopen, movie theaters, indoor dining is available, and the criteria being used to determine which tier a county is in is a combination of case rates, the positivity rate, so that has to do with testing, how many tests come up positive, and also a metric that California developed called health equity. So that is a measure to see that counties are outreaching to underserved populations for equity. So that is what the State Department of Public Health uses to determine the tier that your particular county is in, and those announcements are made every Tuesday. And a county has to meet those criteria for each of these tiers for a minimum of 2 weeks before they can move into the next tier. So that has been exciting to see. And we are now going to be able to welcome Dr. Gandhi to our webinar. Perfect timing, Dr. Gandhi.
Sorry that I couldn't figure out how to get on for some reason, but I am here.
Oh, I knew you could do it. And I've just set the stage for you, Monica, by going over some data relative to case rates and kind of all the positive news that we're seeing. And now we're going to make you presenter, I believe, Pam. And we'll let you control the slideshow from your end, if that's okay, Dr. Gandhi.
Okay, yes. So I will, thank you. So I will share by, people can see my screen. Okay, so can you let me just put up the right talk then?
Yeah, let's put up the PowerPoint, take your time.
And that way, I haven't used this particular way of sharing, but I can do it. I think it just has to be the only thing that's on my screen, I think.
Yeah, just put it up in If it is it a regular PowerPoint or a
Yes, it's a regular PowerPoint.
just put it in PowerPoint view and slideshow view and you'll be good to go. That's the only thing we'll be able to see.
Okay, great. So, what do you see? Sorry.
We see your PowerPoint, so go ahead and put it in slideshow view
Okay.
and you're good to go.
Okay, great. So today, yeah, I wanted to, let me just put it back in. I wanted to talk to you about the COVID vaccines and with an eye to figuring out how society needs to change now that we have these wonderful vaccines. And in terms of restrictions and loneliness and everything else. And so I want to tell you about the vaccines, kind of starting out with their mechanisms, telling you about the ones that we have in this country to focus on that, and then talk about whether the vaccines decrease transmission and try to allay any concerns about the variants, because there's been a lot, too much news about the variants. And then what can we do after vaccination? So there are actually 8 vaccines with phase 3 clinical trial data, which is sort of amazing to be at this point. Only 3 are authorized in this country, the top 3, but there are others that are approved in other places, and they're all shown below. And some of these vaccines, we only have phase 3 clinical trial data in a press release form. We don't even have a full paper on them, including the Johnson & Johnson, because everything is moving so fast. In terms of how most of these vaccines work, there's 2 of them that actually you take the virus and inactivate it. Those are the China-based products, Sinopharm and Sinovac. But all the others involve the spike protein. And the spike protein is how the virus interfaces with the cell. And it has this protein that sticks out from it. And it also has the receptor binding domain. And either the vaccine codes for that whole spike protein or you put that whole spike protein in. But that is, they all involve the spike protein. That was a good idea because they work really, really well. So of the types of spike protein virus vaccine candidates, then we have 2 mRNA vaccines. That's really where there's a lipid layer around the actual mRNA, which you use to code for in your own body into protein. You make the spike protein in your body, and then you produce an immune response against that spike protein. And that is the Moderna and Pfizer are the mRNA vaccines. And then the other type of vaccine is what's called an adenovirus vaccine with DNA in it. So you actually put a cold virus in the body, but not one that can cause a cold in you, but it does cause cold in primates, for example. And then that is the vehicle in which the DNA comes into your body that you code eventually for the spike protein of the virus. And then again, you raise an immune response against that spike protein. And then there's finally one that you literally just put the spike protein in directly. And so these are the type of vaccines, and this is what they stimulate. And I only want to mention this because it becomes important when we talk about the variants, that there are 2 types of immune responses that we get from a vaccine. One is antibodies, and that actually isn't the most important way that we fight viruses. The most important way that we use to fight viruses are what are called T cells, our T cell mediated immunity. And all of these vaccines produce CD8 and CD4 T cells, and they all induce immunity in that way. And so it's really important to remember the T cells when we move forth and think about what these vaccines are going to do and how long they're going to last, which is going to be for a long time. And that when you see a lot of papers like the antibodies don't work against these variants, antibodies is not how we fight viral infections, it's the T cells. And we need to do more T cell work. But the T cell work that we've done shows that these are incredible vaccines. These are really all the vaccine trials put together, but I want to draw your attention just to the top 3 lines because it's the Moderna, Pfizer, and Johnson & Johnson that we have here in this country. And the Moderna and Pfizer are mRNA vaccines, but the Johnson & Johnson is that adenovirus DNA vector. There are 2 doses each for the Moderna and Pfizer, as many people in long-term care facilities and healthcare workers got. And now the Johnson & Johnson just got approved this last Sunday, so it will be authorized to come out. And the important thing on that 4th column is they all raise antibodies against the virus, but they importantly generate T cell immunity. And they actually measured T cell immunity in these vaccine trials. And that's really important because That's what's going to give us our longer durable immunity. The Moderna, the Pfizer, the Johnson & Johnson were all studied in large number of participants that is shown in column 5. Those are all the people who got the vaccine as compared to got like a placebo shot. And if you look down that yellow column, all the vaccines prevented 100% of hospitalizations and deaths from COVID-19. Pretty amazing. There was one hospitalization in the Moderna trial that right after the first shot, they did get sick with COVID and actually had to go to the hospital for a few days. Otherwise, every single one who got hospitalized for COVID-19 in all of these trials, they were in the one that got the salt shot, the saline shot. So they're very effective against severe disease. And in fact, they are only variable in their efficacy against mild disease, as shown in that last column. But across severe outcomes, they're totally as effective across variants like the Johnson & Johnson vaccine, and they're as effective across for severe disease, anything that lands you in the hospital or even needs medical attention. And why is that? Going back to the T cells, it's actually the T cell response that we generate from vaccines that even if this slips into your body, that the T cell response protects us from getting severe disease. It really just swoops in, prevents the virus from setting up shop in the lungs, and makes it so you don't even feel it. So this is the power of T cells, and this is why even with variants, which we'll talk about in a minute, I don't think these vaccines are going to fail. To give you a little more specifics about some of the phase 3 trials, especially older individuals and who was included, the Pfizer vaccine is that one that's 2 doses, 3 weeks apart. And in terms of the demographics, 20%, I'm sorry, I'm trying to move. 20% of people who were enrolled were over 65 years of age. Also, there was some representation, 28% Hispanic Latinx communities, and there was also representation from people with comorbidities, obesity, some diabetes, more obesity though, some diabetes and other conditions that lead to more severe disease. And the efficacy was really amazing. I already told you that anyone who really got sick or had any severe outcome, they were all in the placebo arm. But then even in the vaccine arm, only 8 people got symptomatic COVID compared to 162 in the placebo arm. That means that's a 95% effective rate. And even if you got COVID, the handful of people that got COVID in the arm that got the vaccine, they had very mild COVID. So it is very profoundly effective, more than we ever would have imagined, and very exciting. Certainly for older populations, these side effects, however, are real. They're higher than you get with an influenza vaccine, more injection site reactions, and also more headache and fatigue. Those were the 2 main ones from the Pfizer that were above 2%. They did need these kind of special, really deep freezers. Now you can freeze it a little bit less cold, but it's still a freezer and not a refrigerator. And that has made it a little more difficult logistically for the Pfizer vaccine. The Moderna vaccine trial also enrolled a lot of people, 2 shots, 4 weeks apart, and 25% were over 65 years of age, and also representation, but more representation from communities of color, 36.5%. People were at risk for COVID, meaning there were a lot of healthcare workers, people who had high risk jobs, and then there was comorbidities like severe obesity or pulmonary disease or diabetes. And its efficacy was essentially the same as in the Pfizer trial, this incredible efficacy of almost everyone who gets COVID being in the placebo arm, not in the vaccine arm, and of the severe disease, which there were 30 cases, only 1 was in the vaccine arm. So actually it was 31 and only 1 was in the vaccine arm. So most of the severe disease occurred in people who didn't ever get the vaccine. So it was incredibly effective, lots of local site reactions, and certainly likely more systemic reactions with Moderna, or muscle aches and joint aches. And this has been harder for our older patients, especially very frail elderly patients, to have this many side effects. It's not a flu shot. It gives more side effects. It does take, it can be stored in a regular fridge for 30 days, which is helpful. It likes to be kept cold otherwise. And then finally, the one that we just got authorized is the Johnson & Johnson, and that got authorized this week. It was also studied in a large number of people, but importantly across multiple sites, meaning the US, South Africa, and Latin America. And the reason that's important is there was a lot of representation of diverse racial and ethnic groups. And beyond that, they had more comorbidities in the Johnson & Johnson trial, which led to actually more cases that people could detect. So a lot of obesity and then less hypertension and diabetes. It's a representative trial. And its efficacy, if we start from the things that we care about the most, it did block hospitalizations and deaths by 100%, meaning anyone who was hospitalized with COVID, anyone who died from COVID, 7 deaths, 16 hospitalizations, all of them were in the placebo arm, none in the people who got the vaccine. Also, it was important that it protected against disease equally that was severe across South Africa and Brazil, even though these variants of concern, the B1351, which is the South Africa variant, the Brazil variant, were circulating at high rates in those times during the Johnson & Johnson trial. Its differences occurred in mild disease. It was more effective in the US against mild disease than it was in South Africa, maybe because it's the antibodies that you get against for the South Africa variant were not as high. But T cells, again, what protects you from severe disease, must have been very effective because that was blocked completely. There were more fevers in the people who got the vaccine, but otherwise, actually, adverse events were more common in the placebo group than in the vaccine group they were asked about, and they saw more higher rates. And it is immunogenic, meaning they had to kind of stop the trial after 14 to 28 days to see how you did because they were in a hurry. But the phase 1 trial looked like the antibodies would keep on going up and up. So I think it could be more effective if you waited 4 weeks after giving the Johnson & Johnson. With time, I think it's end up being more effective. And then so I can get time to questions, I don't want to belabor this point too much, but vaccines do block transmission. We always knew they were going to. It's just that what happened in the clinical trials is that people weren't swabbed regularly, but there were always biological reasons to think that, of course, they would block asymptomatic infection and your ability as a vaccinated person to pass it on to others. And not only are there biological reasons, which are laid out here, but now we have the data, meaning now we have real world data of the rollout programs of vaccines, and we're seeing exactly what we suspected, that they don't just block symptomatic infection, they block asymptomatic infection. For example, here is a real world rollout paper in the New England Journal of the Israel Pfizer campaign. They've vaccinated in this particular study over 500,000 people. And after 2 doses, there was 92% effectiveness in blocking symptomatic and asymptomatic infection if you just swabbed and someone was coming in for swabbing, not for symptoms. So incredible efficacy even against asymptomatic infection, which will block transmission. And then this is an example that's being mirrored in long-term care facilities in the United States, that when you get people vaccinated that are older, 90% vaccinated in Israel who are over 60, the cases and hospitalizations in that group really plummet. And this is this is true of data from the CDC in long-term care facilities, that the number of people who are actually getting sick in long-term care facilities, now that we're about 2 months post mass vaccination in long-term care facilities, is amazingly reduced. So these work, they're working well. Much fewer hospitalizations in nursing home settings in this country, which is why we have to think about, again, other aspects of the infection. This is a study from the Lancet about healthcare workers comparing vaccinated versus unvaccinated. And again, it wasn't just a symptomatic COVID disease that was reduced by 85%, and that was just after the first dose, but even asymptomatic infection reduced after the first dose. And that same data has been repeated in a preprint in Lancet from healthcare workers in Pfizer. Again, swabbing people after they've gotten their vaccination, they don't get asymptomatic infection either. After 2 doses, 82% reduction in asymptomatic infection. These are headlines from Israel, but it really is preventing 98.9% of COVID deaths, meaning anyone who's in the hospital from COVID hasn't gotten their vaccine yet in Israel. And it's been a very rapid rollout there. I'll just end with, will vaccines work against the variants? And I will give you a short answer, and the answer is yes. You know, the problem is that we're focusing on the wrong arm of the immune system when the news tells you that they will not. Again, these variants are circulating, not in very high numbers, but they're around the United States, the California, the UK, the South Africa, the so-called Brazil variant. Those are the names that we should call it by their number names. But it really is the T cell immunity that's going to save us. This is a paper just published yesterday that people who had gotten the mRNA vaccine after 2 doses, they then exposed them to variants. They exposed their blood to variants, basically. And they had such a robust T cell response that they were able to completely neutralize those variants. The antibodies varied. And so when you're hearing those stories that these vaccines are going to work against variants, someone's testing the wrong arm of the immune system. And it's T cell reactivity that's going to save us from getting variant-induced severe disease. And so this led Dr. Warner Green here at UCSF to say, even with the South Africa variant, the Johnson & Johnson 1 dose protects you from severe disease, having to go to a hospital. And frankly, that's what we want from a vaccine. That's fantastic. You could have a runny nose or a mild upper respiratory tract infection, but you're not going to get sick from COVID. And I'd sign up for that type of vaccine any day. And I agree, which is our argument for the Johnson & Johnson being a good vaccine. And finally, I won't actually go over masks because I want to end with what can vaccinated people do around each other. Short answer, anything they want. And finally, the CDC is going to finally say this tomorrow in a press release. They will say small groups can hang out with each other, but there's no reason that big groups can't hang out with each other. And if I were running the world, all nursing homes where there is a majority of people vaccinated would be completely open for all the vaccinated individuals to be as close as they would like to be, eating together, no masks, no distancing, because there is no way to get severe disease because you're protected, and also you're not going to pass it to someone else, especially someone who's vaccinated. Vaccinated against unvaccinated, you'll see the party line will still say, oh, we don't know if it doesn't stop transmission. I just told you 5 papers from the real world rollout of these vaccines that these vaccines stop transmission. And I think we're going to need to get away from that message relatively soon with all this data. I personally think that unvaccinated people are perfectly safe to be around vaccinated people without masks or distancing. But the current guidelines are going to tell you tomorrow from the CDC that you still have to mask if you're around an unvaccinated visitor, for example, coming to see you. Again, I think the data is very compelling. That's not going to be necessary. And then unvaccinated and unvaccinated keep all the same restrictions. So, you know, this is what they're doing in Europe to vaccine message. They're showing health officers pointing to their arm saying, I'm doing it I can protect my father. I can go visit him in his long-term care facility. I can organize a big family weekend, get together with my father. And what we say in this country is, yeah, nothing much is going to change. And I really do think we got to change our messaging. These vaccines are amazingly effective. The CDC is being very conservative about it. And I hope that you can make a difference. And I'll stop there and take questions.
That was fantastic, Dr. Gandhi. Thank you. Thank you so much for that quick tour. We do have some great questions that have come in. So
Great.
Thank you for leaving time. So here's kind of a fundamental one as we're grappling, as you know, Dr. Gandhi, with how we're going to safely recongregate again back at our adult day centers. And we can still see your screen. So
Oh, okay. Let me
you can stop sharing. Yeah.
Yes. I wanted to turn off these
I think we
things
can. Yeah, there we go.
Turn off these things from beeping.
That's perfect.
Okay, you got it. You guys must have done it.
I got it.
Okay.
I got it. Teamwork. So here's kind of a fundamental question that we're grappling with is how do we safely congregate? And especially because we have to follow the state and federal guidance, which is lagging, it sounds like the way you're describing it, is lagging some of the science that is emerging every single day. So here's the question. Here's the question. Since the vaccines are not 100% effective, right? So we know 95, although you said that 5% you're going to be protected from severe disease.
Mm-hmm.
Yeah. Can we still be assured that there isn't the possibility of getting an asymptomatic or symptomatic infection that could be passed to an unvaccinated person? So if I'm in that 5%, could I still be asymptomatically infected or mildly infected and not really show much, and then pass that
You
on
know,
to, or is the viral load really low?
well, that's the other thing that I wanted to tell you. With the data that I did not present here ahead of time and was hoping to just say it verbally is that
You've got half an
even
hour,
if you
we're good.
okay, even if you do get exposed to COVID-19, your viral load in your nose is so much lower than if you were exposed before you were vaccinated that you were unlikely to pass it. So there were two articles from the Israel Pfizer rollout campaign where they swabbed people afterwards who were exposed because they were out in society. They were happy that they got their vaccine. They were running around and they were exposed. They kept on swabbing them regularly. And even when they tried to set up shop with the vaccine, with the virus, your cells and your antibodies swooped in and reduced the viral load so that when you got infected, the viral load was 4 times lower than someone who didn't have the vaccine. Actually, the biggest determinant of your ability to pass it on to someone is your viral load in your nose, which is not surprising. So no, I do not think with all the data that's come out, and I mean 2 weeks of data, I mean, this is just brand new, like you said, this is such brand new data, that the world hasn't caught up with it, and we have a very particularly our state has been, I think, reluctant to accept good news. To be honest, it's been a kind of doom-based approach, in my opinion. They need to catch up with the data. I don't think there's any risk of people after vaccination transmitting it to someone else.
So I think that's our challenge right now, is because our facilities are licensed and we do have to follow state and federal guidelines. So
Right.
we'll be eager to hear what the CDC has to say. And clearly there's been problems with messaging since day one.
There has been, and
others
now
have
it's going the other
articulated.
way, right? The messaging at the beginning, there was like too much laxity. Now we're actually the other way. Honestly, we're just all like, the variants are going to get us. The cases are going up. Oh, that's unclear. That's untrue. The cases are not going up in this country. There was a little bit of a reporting lag because of the winter storms, and so when the CDC director said that on Sunday, that's not accurate. Our cases are not plateauing. They continue to go down all over the country. So good news is not messaged, in my opinion, appropriately from the CDC.
Well, bad news gets more clicks too.
It does.
So,
it does.
yeah. So I've got a few clinical questions, if you wouldn't mind.
Yes.
Just to clear up some questions here about the vaccination itself. How long does it take to build up antibodies after Pfizer, Moderna? Is it similar for J&J?
So basically, that's a great question, because J&J, the antibodies kept on coming. Like it was, I keep on calling it a gift that keeps on giving, because the antibodies kept on going up even out to 59 days after 28 days, and was only evaluated after 28 days in the phase 3 study. In the Pfizer Moderna, they seem to plateau out after 2 weeks after the second vaccination. So that's why we say 2 weeks after the second vaccination, you're good to go.
Okay. And could you just describe one more time for us lay folk out here the difference between antibody response and T cell memory, and how important that is as we read about these vaccines and in the press and so on, what we would need to keep in mind?
Yes. So essentially, going back to sort of basic immunology, antibodies are produced by this type of cell called B cells, and they are very transient. Actually, antibodies help you fight bacteria, um, and what really fundamentally helps you fight viral infections your whole life are invoking and stimulating what are called memory T cells that eventually go into your memory bank, like lymph nodes. And whenever they see the virus again, they come out, these memory T cells, and they fight that virus. So it's why even in places, for example, where there's vaccine hesitancy around measles vaccination, there have been outbreaks in certain communities where they're not vaccinating themselves at all against measles. And if it's an isolated community, there'll be outbreaks in the United States. But you, as someone who's gotten your measles vaccine faithfully, your T cells are going to remember that long ago immunity, come out, and even if it's exposed to measles in that very community, you're not going to get sick. And so the T cells are really, I don't know why we're not focusing on them enough, but I think it's because the word antibody is really easy to know, understand, and we've been doing a lot of antibody studies, and it's just soundbite language in a way. Again, not nuanced, complex messaging, because the immune system is complex. But I think it's a shame, because the other day when it was said our vaccines aren't going to work against the variants, completely untrue, completely untrue. It's the T cells, as I just showed you, that you get from the from your response to vaccines will still be able to fight variants that come out. So it's think of it as the more important and strong arm of the immune system that helps you fight viruses, T cell immunity.
Yeah, thank you. Thank you for that. I think that'll help us as we read and listen for key words and how
Yes.
things are being described. And
Yes,
how long
don't listen
after
to
having had a COVID-19 infection, Dr. Gandhi, would one wait to get the vaccination? We know that a vaccine is still needed even if you've had an infection. What's the estimate now on how long you need to wait?
They say 3 months at the CDC. The way that natural immunity to COVID works, you probably don't need it for at least 6 months, but that's okay. After 3 months is fine. And in fact, there's a really good study that shows that you likely only need 1 dose and not 2 doses, because your natural immunity gave you such a boost. And then this is a boost on top of that. But that hasn't gone prime time. So we're still saying 2 doses, 3 months after your infection.
And we're hearing a lot, and even in your Grand Rounds talk a few weeks ago, Dr. Gandhi, and you skipped over the triangle picture that I kind of like.
Yes, but I'm happy to show it, yes.
So you did talk, though, about distancing, masking, and ventilation as sort of 3 factors to be aware of. So until we get the green light from our regulators about if you've been vaccinated and you have the majority of your people, or 80 or 90%, whatever that is, you still need to mask and distance and so on. Of those 3 factors, I think I know your answer. What is the most important for us to be following until we do get that green light kind of guidance?
If I could share my screen though one more time.
Oh,
and
sure.
To make
Let's
me
do it.
have that ability. Oh, great. Okay.
Oh, Pam is doing it. Okay.
So yeah, I mean, the important thing to remember about these 3 what are called non-pharmaceutical interventions to prevent COVID-19 transmission is there's no absolute science, actually. If you are outside, so you have more ventilation, then your mask doesn't have to be double fit or filtered. None of that, because you have the outside going for you. If you're in a place that there's less distancing, like a schoolhouse where there's 3 feet distancing, 2 feet distancing between people, not 6 feet, you would want to use a stronger mask. So they actually are what are called complementary, and host susceptibility and being older is in the middle, meaning you want good NPIs on board if you are unvaccinated and in the middle. Host susceptibility goes massively down, almost down to 0 for severe disease once you're vaccinated. So masks, yes, I mean, it's true. I think masks are very effective. But when I think about I mean, I know they won't let you do this, but I would not, the biology tells me that vaccinated individuals within a nursing home can just be around each other with 0 restrictions. But before that biology catches up with the recommendations, or the recommendations catch up with the biology, it can be any of these: masks, distancing, ventilation. They're probably going to require masks and distancing. Ventilation is as simple as opening a window. Again, transmission is not going to need, with after vaccination, all these this much of a degree of NPIs. I would not recommend any double masking or stronger masks after vaccination because you're so protected. So simple cloth mask, surgical mask, you're trying to get people to visit, and be able to be around each other, and a double mask or an N95 mask is very restrictive.
We have some staff and some participants who are still concerned about the vaccines. And while our collective community here has been doing a really good job on educating folks, I think there's still an expectation there will be some people that just are not ready. It may take them a long time, if ever, to get ready to be vaccinated. So especially, given your experience with HIV and your clinical practice, what are some of the things that you share with people to both listen empathetically to what their concerns are, but also in terms of your approaches to trying to move them along to what I call, I heard on the radio one day, a slow yes. They just need to
Yes.
be moved along, a slow yes. So do you have some?
I think it's a great question. And, I think there are three things that I talk about. One is that, boy, these vaccines seem like they were rushed. And that is a big concern that people have. Actually, if you think about the way that they were made, they actually weren't rushed. What I mean by that is that you don't need to use live virus. No one has a special fancy lab that we're making these. You actually just needed the sequence of the virus to be able to make these vaccines. And we got the sequence of the virus in the world in January 26, 2020. We had it really early on. So it was really easy to work off the sequence to make an mRNA vaccine. Second is that mRNA vaccines have been looked at for cancer and other pathogens. There just wasn't one in prime time to be out there. And third is, if you're in the year 2020 and your whole world comes screeching to a grinding halt and you get a huge amount of money, you're going to make a good vaccine. And that's what Operation Warp Speed and all this funding did to help people get over the barriers and get to a vaccine. The second thing that I say is that the mRNA degrades very quickly in your body after you produce a protein, so it's not going to go inside your cells or do anything that causes long-term damage ever to your body, which is a concern that people have expressed. And the third is that they actually enrolled people with more diversity than usual vaccine trials.
Mm-hmm.
The Johnson & Johnson vaccine, I've been told from Latinx communities that by enrolling 45% Hispanic and or Latinx, that is helpful to have a population that reflects the demographics of the pandemic. So that attempt to get older people, that attempt to get more diversity, I think should hopefully feel that there's more representation in these trials. And then the final thing I want to say about it, and if I can share my screen one more time, is that not all of us have to get vaccinated. So I think, Pam, you have to give me the control.
I've got you.
Okay, great.
There you go.
And what I wanted to show you here was not this, but not this, but this. Do you see this?
Oh, yes. The
Herd
herd
immunity.
immunity
Okay.
picture. Yes.
So what I wanted to show you here is, I had someone make this for me and I love this, just because I like the color pink, and I also think I happen to love sheep, though maybe I can think of another animal. But in this case, we made this diagram to illustrate herd immunity. That when there aren't enough white, not enough pink sheep who are immune, then white sheep who can pass it to each other are close to each other. After you get more and more people vaccinated, or more and more sheep turning pink, you can see that two white sheep are actually not even close to each other in the field. They're too far away from each other to pass it. And the virus fundamentally slows down on its own. It can't find anyone to infect. So we don't actually all need to get vaccinated. And if certainly people, there's self-efficacy around that, and we don't need to all get vaccinated to get herd immunity. We are seeing the cases going down massively in California. It is not just because we're all sitting at home. That is not accurate. It is partially because of immunity from vaccinations. We have about 20% of Californians vaccinated at this point. All of that is bringing the cases down. And at a certain point, we are going to know when we've reached herd immunity, because the cases are going to be so low. And of course, the hospitalizations are going to be low that's what the vaccines do. So there will be a moment where we'll know that we're there. And if you really, it doesn't require full 100% of vaccination.
So there have been so many different estimates, including our dear Dr. Fauci, changing sort of, raising up
Yeah.
his estimates over time. Do you have your own favorite percent number that you think we're going to
Yes.
need to hit?
Yes. I mean, when I see what's going on in Israel, that they're moving so fast, and in the UK, and I'm seeing how fast things are happening for them, I think it's going to be no more than 70%. I do not agree it's going to be 80% or 90% to reach herd immunity. I think it's going to take 70%. And they're getting there. They have 30% of their population vaccinated in the UK. And combined with natural infection, it's a very rosy picture there.
Dr. Gandhi, will we be able to get there though without the vaccination for the under 16-year-olds being a large percentage of our population? Do you think it's going to take that to get us there?
I don't think children need to be vaccinated to get us there because
Okay.
there are about 270 million people over 16 in this country, and we don't actually have as many children as you think. So our
Okay.
16 and under population will still get way above 70%.
Okay.
And of course, they are doing vaccine trials in 12 to 15-year-olds, but I do not believe children it will not be necessary. And this is not a population who gets very ill, so I think we can certainly wait for those vaccine trials, but we'll get to herd immunity before that.
So some big thank yous are coming in, really informative. Thank you for giving me hope. So some comments like that
You should be hopeful. These are amazing. I don't know how to explain it any more than I am. I gave you the data pure and simple. I did not sugarcoat it. This is the data. Don't listen to anyone who's trying to make things seem depressing right now. There's no reason for it. We're just a dour country. I don't know what we're doing.
We do have people with other diseases besides COVID, right? In our
Right,
center.
and we also have people with loneliness. We have people with depression. We have people with anxiety. We have people who have not seen their families for a year. If I were the CDC director, I would message in minutes. I would not take days to open up long-term care facilities. The data is very compelling, and the data on the other end is very, very difficult for people.
Do you think that you talked a little bit about the longevity of the vaccines and how optimistic you are? Would you again then predict that we won't need a booster every year like we do with other? Okay.
No, we won't, because the influenza virus has a very leaky polymerase. It mutates actually very quickly. This is not mutating that quickly. We just somehow get informed minute to minute by every variant that's in this country, by our dour press. But this is not mutating this quickly. It really isn't. And it's not a what's called leaky polymerase. It has a very strong proofreading mechanism. I don't think we're going to need yearly vaccines. We are not. And beyond that, I think that vaccine-induced immunity, at least by one model from natural infection, looks like it's going to last about 10 years. So I am not worried that we're going to need yearly booster shots at all. Again, I would turn off that noise. I'm not sure what's going on with the press. I really don't.
It's so hard because we are not scientists like you, and we don't have the ability. So that's why we need to count on people like you, Monica.
Yes, then you can call me anytime, and I'll explain exactly what they're trying to talk about, because they're making me so mad.
So a couple other clinical questions and then one on sanitation. So could you review for us quickly what are the contraindications to getting a vaccine, a COVID vaccine?
Essentially none. I mean, they used to say if you have a reaction against other vaccines, but even that has gone away because anaphylaxis is so low when we saw in the clinical trials. And there is something called PEG that is in the vaccines that could have caused those anaphylactic reactions, but there are very few people who've had reactions to PEG, and we're not even sure that's what it is. It's polyethylene glycol. So for now, they may say if you have a PEG allergy, be watched. I wouldn't even not get it if I had a PEG allergy because it's not definitive. There's really no contraindications to getting it.
Okay, and including
but
pregnant
you should
women.
Be watched. If you've had anaphylactic reactions, you should be watched. For longer, like to other things, you should be watched for longer than you are watched usually, meaning for 30 minutes after the vaccine instead of 15 minutes.
Okay, and pregnant women? Can you
Pregnant
review
women,
that?
I encourage them to get the vaccine. There's nothing in it that would be harmful to the fetus. It's an mRNA vaccine, nothing live in there. They are doing a Pfizer study of 4,000 patients to see who are pregnant to make sure it's safe, but I don't see there's any reason why we don't think it's safe.
And it really, isn't that risk benefit
Yes.
harm reduction calculation we have to
Exactly,
make?
because
And you do
COVID
as
in pregnant
doctors.
women can be difficult, right?
Yeah. Okay, great. Somebody says, thank you for explaining the difference between antibodies and T cells. Very helpful. So we love our science classes here at Web Talk. We really do. Oh, sanitation. So again, if you were sitting across the desk from somebody from the Department of Public Health or Healthcare Services, clearly we have to follow universal precautions because there's stuff other than COVID out there. But would you be quite as obsessive about the physical plant sanitation relative to COVID at this point, or has that?
No. At this point, we have so much data that this is not spread by surfaces and fomites. And unfortunately, we got into a habit in some places and all that disinfection and deep cleaning. I'm very worried about it, actually. I think it can cause antimicrobial resistance in the future. Simple, basic hand hygiene. Not even for this, because there's never been a study that washing our hands changes your transmission of COVID, but just for other things. So yeah, I wish that would be dropped, but it's hard to get people to go back.
Hmm. Yeah, I heard you talk about microbial resistance, and that made a lot of sense to me, actually.
Yes, all those we if we get into bacterial wipes that we get antimicrobial resistance to bacteria, then that's what's going to be a consequence of when we say we have no harm of our actions. They're clearly harm of our actions if we go too far with COVID.
I think I'll come back to that before I let you go, but somebody says or makes a comment that there have been delays in getting a second dose due to shortage of supply.
Yeah.
How long is it okay to wait until the second dose if there is a shortage in their area?
No concerns about waiting, and in fact, I would go out to 12 weeks and be happy. That's what they're doing in London, in the UK. They have good reasons to do it. It looks like the AstraZeneca, at least, the longer you wait between doses, the better. And there's data from vaccines in general that the longer you wait from doses, the better. So I'm happy with 12 weeks, and in fact, I was one of the ones pushing for in this country that we extend the duration by 12 weeks, but no one listens to me.
Okay, great. So we have a lot of things we can control in our adult day healthcare and our adult day programs. Dr. Gandhi, in terms of staff, vaccinations, masks, and so on. We have less ability to have control over the environment, say in public transportation or paratransit or something like that. So given what you've just said about fomites and not being so worried, what about still confined spaces where we don't know who's been vaccinated or not vaccinated on that vehicle? Would you still highly recommend masks at that point?
Yes, I mean, we are not going to abandon masking guidelines at all until we reach herd immunity. So
Okay.
you won't even be able to get on that bus without a mask, and the windows are going to be open. So that is the appropriate thing to do because we're so mixed up between those who are vaccinated and those who are unvaccinated, and we can't tell. So I would definitely maintain masking and distancing for your family members or people who are traveling on the bus.
Okay, distancing not as important on a bus if we have our double masks?
It really isn't because again, that complementary triangle. So do the double mask on the bus and then you don't need it. You can sit right next to someone.
Okay. Well, we're just about at 12. I'm going to let you go. I want to just close with making a comment to everyone, and that is I invited Dr. Gandhi on today, and she was gracious enough and gave us the generosity of her time and wisdom because she believes in what you all are doing. And she is passionate about her work. And that's why I was so attracted to her from Grand Rounds. I told her I was a fangirl from day one. So,
and your daughter is wonderful.
So we appreciate that, and we know where your heart is, and we know where your mind is. So we appreciate your offer to come back and run some things by you as we sit down with our state partners and figure these things out.
Please, and I'll
So
send you this talk, show them all the data on it preventing transmission. We're in 2 weeks later, makes all the difference with data.
I'll
on
do
this-
that.
on these
I'll do
vaccines.
that. Now,
I'll send you
given
these.
all the hope today and all the wonderful response, people should not take this as rushing out and bringing everyone back into your centers. We still have to follow our Department of Aging and Department of Health and Public Health guidance. But I think what this does, Dr. Gandhi, is it really helps us think through what those steps might look like, keeping track of vaccination rates and so on. And that's just going to be immeasurable in our work. So thank you so much
Thank
for
you.
joining us today. Pleasure.
Nice to see all of you. Thank you so much.
Thank you.
Okay, bye.
Bye-bye, Dr. Gandhi. So that was Monica Gandhi, everyone. As you heard her describe the science and the data, I hope this also gives you a little more of a analytical, critical filter through which you can now process information that you're hearing in the media, and it added to your understanding of COVID so that you can also explain this to your participants and family members and caregivers as you speak with them about the vaccination. So stay tuned for more direction, more guidance, more instruction from the state, from your managed care partners, from us on Web Talks to give you some operational guidance. We're continuing to meet hours and hours each week to think all these things through, and we'll be sharing that information with you as we develop it. And you heard Jill say earlier today, there will be guidance coming out in April. So in the meantime, sit tight, don't change what you're doing. We're still not at herd immunity, and we're still needing to focus on getting as many people vaccinated as we can with your efforts. So I thank all of you for all the work you're doing in that regard. So as we wind down here, as always, I want to review with you the upcoming opportunities for education. March 10th, I want to point out at 10:30, the same time slot as Web Talks, CADS will be hosting a webinar titled Empathy in Elder Daycare, The Practical Connection. And this is by a very popular presenter, John Ford. Some of you may have already heard him speak at conferences. And we've talked a lot about empathetic listening, particularly as we talk about COVID and vaccination. So I encourage you all to sign up for that webinar. Pam has gotten information out on that already, and signups are being accepted as we speak. I don't have firm commitments on my next two Web Talks, March 17th, and then we're going to April 7th. But I want to start talking about preparing your facility, and then talking about the Cal-OSHA model staff safety plan. So those are up there just as topics. I'm not promising you that's going to be the order or on those dates, but we are thinking about that now. And then I just wanted to point out that we've gone from every week to every other week, and now we're moving to a first and third Wednesday of the month for these Web Talks. So if you want to go ahead and note those on your calendars, 10:30 to noon. If something important comes up in the meantime, we'll squeeze another Web Talk in, but we're regularly going to hold them the first and third Wednesday of each month. Okay. So as always, I close with a thought for the week. And this one struck me as particularly pertinent today. The pessimist complains about the wind. The optimist expects it to change. The realist adjusts the sails. So this is a quote by William Ward, who I had to look up. I had not heard of him before. He's an American motivational speaker. He was in the early part of the last century. And it struck me that this is what we've been about during the whole time of COVID, is realism balanced with hope and balanced with optimism. And I'm hoping that today's talk with Dr. Gandhi left you with all three of those things to keep in mind and with you at all times. And I think what I can say is we'll be adjusting our sails as we move into 2021 on the winds of vaccine supply, vaccinations, and continued mutual support as we have done over the past year. So thank you for joining us, everybody. Stay well, continue to mask up, keep working on vaccinations, and we'll see you again on March 17th. Thank you again to our presenters, Richard, Jill, Dr. Gandhi, all of you for being here, Pam, for your behind the scenes support. Thanks, everyone. Stay well.